All right, so I'm not entirely sure where I ended up, so I'm going to start right here with bronchodilators. When you've got a patient that needs a bronchodilator, the big thing is the law of supply and demand is not being met. So the first thing that we're going to do with these patients before we give them any type of medication is we're going to give them oxygen and lots of. Now, after we get the oxygen on and we get it flowing, now we're going to give them a bronchodilator. And there are several types that we're going to look at. Bronchodilators can be divided into selective and non-selective agents when you are giving them. Selective agents primarily act on the bronchial smooth muscle. So they are targeted into the bronchi themselves to help them open up and thus cause air to begin to flow. The nice thing about selective agents is that they don't have a huge amount of side effects as we would see with non-selective agents. The side effects that we're looking at here is going to be tachycardia, hypertension, causing our patient to become anxious because the sympathetic nervous system has been kicked into drive. Now, when we're looking, you got to keep in mind that everything has its limit. And so if we give high doses or multiple doses of bronchodilators, and we may need to, it could potentially lead into alpha and beta 1 response. Please go back and review what happens when we have alpha 1 and beta 1 responses for our patients. Now, when we're looking at this, most of these medications are going to be selective for the beta 2 receptor. However, you really do need to be cautious when you're giving this as well as any other medicine. So, as we're looking at this, we want to be really careful in utilization of beta 2 agonists if we've got a patient that has a history of heart disease. These patients need to be placed upon a cardiac monitor right away, and thus now what's going to happen is that we'll be able to watch how well their cardiac status is from both an EKG as well as a cardiac output. Now, some examples of beta 2 agonists that you're going to be really familiar with in particular will be albuterol, which the main name for albuterol is Provenal, or terbutaline, also known as Brethine. With non-selective agents, we can see them that'll act on all alpha, beta 1, and beta 2 receptors. And as a result of the alpha stimulation, we're going to get peripheral vasoconstriction, which will result in what? Increased blood pressure, okay? Beta 1 stimulation, again, beta 1, one heart, will cause increased tachycardia and more of a enhanced cardiac contractile force. So we can potentially have an increase in cardiac output, but again, remember, afterload is also going to be effective. So the vessels that the heart is going to kick the blood out into are going to be narrow. So that may decrease our cardiac output as well. Beta 2 stimulations, now what's happening here is we get bronchodilation, which is exactly what we want. Now, again, keep in mind racemic epinephrine, we'll talk about this a little bit more later, is a non-selective bronchodilator. So it will affect both alpha, beta 1, and beta 2 receptors when we're looking at this. Now, as far as diseases go, asthma is considered to be a mild disease that can most definitely become life-threatening. It can be caused by intrinsic or extrinsic triggers, intrinsic within the body, extrinsic with outside of the body, and you see some of the both causes that are going to be there. The big thing that we want to do, and the big thing that your patient wants to do, is wants to focus on prevention. Keep the patient from having an asthma attack. How do they do that? Well, they will often use inhaled steroids. If you watch television, you will see a number of advertisements for inhaled steroids on TV now. And in that, they will often make the statement, not to be used as a rescue inhaler. These medications that are advertised are for prevention, not for treatment. The big thing, though, when we do have a patient that has an asthma attack is that we've got to reverse the bronchoconstriction to get air in there. And how do we do that? We do that by delivery of inhaled medications, which is kind of a two-edged sword, because if our bronchioles are very, very narrow, very, very tight, getting the medicine down to where it needs to go can often be difficult. If we're not able to do that, then we can go to IV medications. Albuterol and Ventolin are the most common given, as we talked about a while ago. Although there is a relatively new one called levalbuterol, trade name is Xopenex, and basically what is this purified form of albuterol that has a lot of fewer side effects. We use this a lot when I worked down in Georgia, but for the most part right now, what you're going to begin seeing and utilizing is going to be albuterol. Adrenergic agents such as albuterol work more centrally within the bronchial tree to bring about vasodilation. Now, cholinergic agents such as ipratropium are actually more effective in the peripheral airway, so the bronchi themselves, to cause dilation as it's going. Adrenergic agents are more effective with asthma, whereas the peripheral action of ipratropium will often give you greater benefits if you've got a patient with COPD. Now, when we're talking about COPD, we're primarily talking about chronic bronchitis and emphysema. Although, and this is important for you to remember, asthma is indeed a type of COPD, so you want to kind of keep that in mind. So let's look at some of these specific medications. Ventolin is a bronchodilator that is a beta-2 agonist. It stimulates the beta-2 receptors, causing bronchodilation and allowing more air to come into the lungs. When do we use this? Well, basically for any time that you've got any kind of bronchoconstriction, such as asthma, bronchitis. Now, you don't always have bronchospasm with bronchitis, but you can. And so if you're hearing wheezes with a patient that you suspect has bronchitis, then most definitely Ventolin could come into play there, or any type of COPD for your patient. Some of the adverse effects, and I won't ask you to name all of these, but again, one of the things you keep in mind as far as when we list these, the adverse effects go from the most common down to the least common, okay? Now, Ventolin can cause an increase in blood sugar, so we want to be aware of that. An increase in blood sugar is probably not going to kill our patient, but we do want to be aware of that it will cause the blood sugar to go up. It will also cause a drop in potassium. That's very important if you've got a patient that has a long-term history of low potassium within the heart. It can raise the heart rate, sinus tach, cause palpitations, resulting in anxiety. Their hands may begin to tremor. Blood pressure goes up. Again, sometimes it can lead to epistaxis or nosebleed if it is causing really, really severe vasoconstriction of the blood vessels. Some of the contraindications is if the patient has angioedema. Angioedema is a symptom of an anaphylactic reaction, and we want to be really, really careful in doing that. The other areas we want to be careful in is lactating patients. If you have a mom who is breastfeeding her child, you want to weigh the benefits versus the risk. And obviously, if you have something else that maybe will not cross over into the breast milk, you might want to take that into consideration as well. Your dose for Ventolin for a bronchospasm, as far as the adult, is going to be 4 to 8 puffs every 1 to 4 hours. Okay. Now, most likely, if you're going to give Ventolin, you're going to give it into a nebulizer. A nebulizer is basically a small cup with a small amount of normal saline in it, and we dump the medicine into that to get a dilution. And they kind of puff on what we call a pipe, or we can put a mask on them for them to breathe it in. And the way we're going to do this is we're going to go 2.5 to 5 milligrams every 20 minutes for a maximum of 3 total doses, okay? Now, if you get to the 3 doses and your patient is still having a problem, we can actually double or triple that dose to go up to 10 to 15 milligrams per hour. As far as when we're looking at Ventolin with an MDI, again, what we're looking at is 2 breaths through, most likely through a spacer, which holds the medicine in place so that they don't have to begin to look at that and try to breathe it as it comes out. Moving on to levalbuterol or Xopenex. Remember, we talked about Xopenex being the purified form of albuterol. It is true, it's a beta agonist, which results in stimulation of the beta 2 receptors, and it will cause smooth muscle relaxation, not just in the lungs, but anywhere else that you would have smooth muscle going on. Your indications, like all of these medications, is going to be for a patient that has a sudden onset of a bronchospasm that's going to happen. The adverse effects or side effects are going to be pretty much the exact same thing that you're going to be looking at. Contraindications, pretty much going to be the same thing. I do want to draw your attention down to bullet number 3. Under contraindications, it says don't use in patients taking phenylthiazines, because this can cause a prolonged QT interval and cardiac arrhythmias. Now, I don't expect you to know what that means right now, so the big thing I want you to know is it could cause your patient to have some cardiac issues. Phenylthiazines are used to treat serious mental and emotional disorders such as like schizophrenia and other types of psychotic disorders on your patient. As far as if your patient is getting beta blockers, you probably want to go to something else because it can actually cause some additional heart arrhythmias for that particular patient as you're doing that. Now, the thing I want to keep in mind here is the things that can happen as far as your dosing goes is basically 2 inhalations every 4 to 6 hours if you're giving it through an MDI. But with Xopenex, again, the better way to do this is through a nebulizer. And when you get an advanced sequence, you'll learn about how to use a nebulizer in the lab as far as using that. Now, another drug, Atrovent, ipratropium bromide. Sometimes we just refer to it as ipratropium. It is both a bronchodilator and an anticholinergic. And basically what it does is it blocks the acetylcholine receptor on smooth muscle, particularly within the bronchial tree, resulting in bronchodilation and more air to be able to come in. Indications are the same as what we've seen with other bronchodilators. Now, one of the weird things with Atrovent is that it can actually worsen bronchospasm, but that is rare. Generally, we're not going to see that. It can cause your patient to begin having a cough, which in and of itself is actually a good thing if we get a bronchodilation, because now it begins to bring up some of the mucus that is within the lung tree. In particular, I want you to look at the fact that it says it can lead to a dry mouth. Any type of anticholinergic medicine that you're going to give can dry up secretions. Now, let me ask you a question. What cardiac drug have we talked about that can lead into a dry mouth? If you said atropine, you are correct, and it is an anticholinergic that you're going to be looking at. For your dosing, again, I want you to focus more on the nebulizer dose of a 0.5 milligram every 20 minutes for up to 3 doses. And then one of the things I would tell you to do is if you are on a long distance transfer, you're working in a really, really rural area, I'd tell you before you gave a 4th dose, make sure that you're going to talk with your med control to find out exactly what they want you to do. Now, Atrovent is often not used as the only medicine, so we can basically follow this up, or we can give this after we've given like one of the others. Xopenex would be a good example. The other thing is make sure that you don't allow the fumes, especially from a nebulizer, to get into your or your patient's eyes. Again, because it is an anticholinergic, it will cause pupil dilation that will result in having blurred vision for the next several hours, just like when you go to the eye doctor. Now, we have a medicine called Duaneb. Duaneb meaning that's two types, and basically it's going to be the combination of albuterol and ipratropium. It's a combo type of bronchodilator. And again, it stimulates the beta 2 receptors within the lungs and results in bronchorelaxation for the patient to be able to breathe. A Duaneb is going to be a second line medication that you're going to administer to your patient after you've given probably albuterol by itself. Some of those adverse effects, again, we're going to have increased heart rate, increased respiratory rate, jitteriness, blood pressure may go up, patient may have a headache. If you're going to do an MDI or a meteor dose inhaler, you're going to give 8 inhalations every 20 minutes for up to 3 hours. That would be if you're with a patient for a long time. But more likely what you're going to do is you're going to take 3 mils and put it into a nebulizer with about 2 to 5 milliliters of normal saline and allow the patient to breathe through that or breathe that until the steam, it's actually not steam, it's an aerosol. It's very, very cool, which is good for the patient, but until that aerosolization is gone away. Now, the clinical picture of a patient having an asthma attack or a worsening of COPD is that of a patient that is gasping for breath. They're using all of the extra muscles in their chest and in their abdomen and wheezing. In asthma and COPD, bronchodilators will provide symptomatic therapy, but they don't treat the underlying problem. One of the things to keep in mind when you're dealing particularly with asthma patients is they can suffer from what's known as a silent chest. The bronchioles will close down so very tight that it results in no breath sounds that you're going to be able to hear. Now, you can probably hear some very, very faint breath sounds in the upper lobes of the lungs, but your silent chest will be down in the lower part of the lungs themselves. Now, when you've got a prolonged transport time for your patient, okay, begin to think about giving them a steroid that basically will treat the inflammatory process that comes about and brings about both asthma and COPD. It's going to take several hours for that steroid to begin to work, but recent studies have shown that patients have a much better outcome if they get that steroid early. So, yeah, it's probably not going to start working for at least another 3 hours. And in all means that in cases you're probably going to be finished with your patient, but go ahead and give that to them now. Now, the most common types of steroids that we're going to use are going to be methylprednisone and dexamethasone, and both of them seem to be as equal as being effective as the other. So let's look at dexamethasone. Trade name is called Decadron. Now, what it does in both of these reduces inflammation by multiple mechanisms. How it reduces inflammation, I don't really care. Now, we can utilize this for a number of reasons, including asthma, if you got swelling of the airway, if you're, let's say you get to work out west where you're at elevations above 10,000 feet and patients now begin to develop acute mountain sickness, as well as Decadron will slowly reduce edema that develops within the brain itself. Now, the pharmacokinetics and pharmacodynamics of corticosteroids in kidney impairment are not well understood, but the half-life is decreased in patients with severe renal failure. Some of the adverse effects that you will see, particularly with these patients, is long-term use can lead to not only depression, but all types of other mental illness types of problems that will basically be transitory and they go away when you stop the steroid. One of the things that you will see, though, is that these patients will begin to retain fluid, and whether they're a diabetic or not, their blood glucose level will begin to go higher. Your dosing regimen that you would give for these particular patients is going to be 20 milligrams for your patients. Another drug is called methylprednisone, or commonly called trade name Solumedrol. Again, it works by reducing inflammation. Side effects are going to be the exact same thing as Decadron that we saw just a minute ago. Now, be really careful for either one of these steroids that you're going to be utilizing if you got a patient that already has an active infection. Steroids depress and decrease the immune system, which can actually make the infection worse. But again, remember Bill's number one rule: treat what's going to kill your patient first. Now, Solumedrol is used not only for bronchospasm, but it can be also helpful for patients that have anaphylaxis. For asthma and COPD, basically what we're going to do is we're going to give them 40 to 80 milligrams, and we can give that in 2 or 3 doses. For anaphylactic shock, it's going to be weight-based, and we're going to give a half to 1 milligram per kilogram every 12 hours for these particular patients. Make the math easy. Basically, I would tell you, just go with 1 milligram per kilogram, and that will make it a little bit easier. A third, second-line drug that we're going to be looking at is magnesium sulfate. Mag sulfate is very helpful as far as use within the pregnant patient. We'll talk about that a little later. But what it does is that it can also help to control seizures in the pregnant patient, and it also is a good vasodilator to bring blood pressure down. Now, with mag sulfate, what we're looking at here is mag is indicated for torsades, but it can also be indicated in patients that have status asthmaticus. Briefly put, status asthmaticus is a condition in which you've done everything you can to get your patient's asthma attack to stop, to break it, and nothing that you've done is working. And now we've got to go over to something else, and so we're going to go with mag sulfate. One of the things you got to be careful, though, is, again, mag sulfate, I want you to think of it an awful lot like a benzo that can cause a drop in the blood pressure. It can cause our patients to begin to have some reduced muscle use, and it can have some negative effects on the patient's cardiac system. You see the contraindications there. If we've got a high degree AV block, we're not going to utilize that, and we need to be really careful, as we are with all other medicines, anytime that we're utilizing medicine that has a patient that has renal impairment. So here's your dosing. Again, I want you to know this for both your cardiac as well as your status asthmaticus. Basically, if we've got VFib, pulseless VFib, or torsades, we're going to give them 1 to 2 grams in 10 milliliter of D5, and we're going to give that over about 15 minutes. Now, the slide says faster with cardiac arrest, and we can get that in a little bit faster because the patient is dead. There's not a lot that we're going to be able to do for them. If we got a patient with torsades with a pulse, or if we got a patient that we are knowing that our patient has a low magnesium level, again, we're going to give 1 to 2 grams in 50 milliliters or 100 of D5W. You can also give that into normal saline, and we're going to give that over 5 to 60 minutes. What I would tell you to do is to split the difference there and give it to your patient over about 30 minutes. For eclampsia, this is a condition in which our patient now begins to have seizures as a result of toxemia of the pregnancy. We're going to give 4 to 6 grams IV over about 20 to 30 minutes, and then we'll follow that up with an infusion of 1 to 2 grams per hour. Again, we got to watch our patient's level of consciousness, and we've got to watch our patient's ability to breathe, because it will cause them to stop breathing if we give it too fast. Last one in here will be status asthmaticus that I've already shared with you, and we're going to give 1.2 to 2 grams slow IV over 20 minutes. Now, again, as we said earlier, when we're giving these small amounts, what you're going to want to do is you're going to dilute it with about 150 or 100 milliliters of normal saline and set it up so that you will give it that way. You're never going to be able to give the small amount of 2 grams over 20 minutes through a syringe. Now, we talked a little bit about racemic epinephrine. It's a bronchodilator. It's also an adrenergic agent. Remember, adrenergic agents lead to an increase in the sympathetic nervous system. Now, the epinephrine is a really good drug in the fact that it will cause a reduction in the swelling of the mucosa of the bronchioles, as well as leading to bronchodilation. Racemic epinephrine is really good for asthma, but it's also good for your pediatric patients that have croup. As you can see there, all of the same side effects that you will see will be some of the same ones that we talked about when we were discussing epinephrine as far as a cardiac drug. So none of those have changed. You do want to be careful if your patient has got glaucoma because it can increase the pressure in their eye. Again, if you are at the point of where you're needing to cause a bronchodilation, that's going to come first. So what we're going to do is we're going to have about a 2.25% solution, and what we're going to do is that we'll put that into a nebulizer at a dosing range of 0.05 to 0.1 milliliter per kilogram, and the maximum dose that you're going to give for your patient, regardless of what their weight is going to be about 0.5 milliliters. For the adult, again, take it, put it in the nebulizer, make sure that it gets mixed up, and then administer over 15 minutes or so, or until the mist begins to stop. Some of the things that you want to be aware of when you're looking and giving racemic epi is, again, remember, this is an epi. This is a sympathomimetic. If your patient has a history of cardiac disease, you want to make sure that the risk is worth the benefit for your patient. Now, when we give racemic epinephrine, it's going to go into the lungs, and keep in mind, medicine that goes into the lungs gets picked up into the vascular system almost as fast as if we gave it IV. So it's going to start working really, really quick. Now, the nice thing about giving it through this method is going to be that your patient will have the good side effects or the good positive effects of this for your medications for as long as 3 hours. Again, you want to watch your patient really, really closely. So as we close this section out, keep in mind just a few things to review. COPD is a classification for diseases that cause any kind of a obstruction within the pulmonary tree itself. The two most common types of COPD are going to be emphysema and chronic bronchitis, although asthma, we can make an argument that asthma fits in there as well. All three of these pathological conditions, emphysema, chronic bronchitis, and asthma, cause an increase in sputum production, and now we have bronchospasm. So the bronchioles get much smaller, and they get clogged up with the sputum that comes into play there. As the sputum gets worse and increases, it can irritate and lead to a bronchospasm, which is a sudden closing of part of the lower part of the airway. The initial treatment of mild to moderate COPD and asthma is aimed at two things. One, we got to reduce the bronchospasm or the bronchoconstriction. And number two, we've got to allow our patient and encourage our patient to cough up some of the sputum that's in their airway. One of the good things about most of the medicines that we've talked about in here is that they do trigger the coughing reflex, which will help to bring that sputum up. Again, ladies and gentlemen, if you have any questions about this, don't hesitate to reach out to me.